Good morning or afternoon or whatever time of day you choose to think it is at 98 degrees. I'm Jamie Gaines, I'm the manager of state government relations. So today I'm turning my ringleader duties over to Kate Guinness, our director of behavioral health advocacy. Thank you to everybody on Zoom. If you have any issues with the tech, please type it into our chat box and we will do our best to address it. And with that, I'm going to turn it over to Kate.
Thank you, Jamie. I'm just going to lower this thing if I can, so that I can see you all more. I'm going to stand on my tiptoes. I never don't wear heels except today. So thank you so much for coming. This is going to be a little bit of a technical talk, and I will just preface it by saying our aim is to be done by 20 of at the latest, so that there is a robust amount of time, unlike our usual minute and a half for questions, that there really is time for questions, because I know I have already been getting questions over email, etc., and I know that people are really invested in understanding what's going on. So I'm going to also wonder why we're not advancing. There we go. Okay. So I'm Kate Guinness. I'm the Director of Behavioral Health Advocacy and Policy in the Government Relations Office for the hospital. Many people know I was previously, for a long time, a clinician in the emergency department, so I kind of see things a little bit through a clinical lens, but have been doing policy work now for 5 years. The issue that I'm going to be talking about today is near and dear to me, because it's the first thing that Josh Greenberg, who's here, who's the Vice President of Government Relations and my boss, it's really the first thing that I walked into Josh's office and I said, can you believe that this is a thing? And now we're talking about implementing a policy change related to it. So that is really exciting to me. It is something that I came to be aware of because I was a clinician, and I saw, when we see patterns of things that don't work for kids and families, that's when we say, you don't want to fix them one at a time over and over again. You really want to think about working with policymakers to make change. So my job is now to do that. I depend now, because I'm not in a clinical role, on all of you and your colleagues to really hear about what's going on the ground. And then I have the lovely job and wonderful job of being able to work with policymakers to make change. With us, speaking of policymakers, is Emily Sherwood, who's the Deputy Commissioner for Kids and Families at the Department of Mental Health. I will also say that Emily, in her previous, can folks on Zoom hit mute, please, if you're not muted? Thank you. Emily, in her previous life, was the person who oversaw the implementation of the Children's Behavioral Health Initiative program in Mass Health. So she really knows this issue intimately. So we're really lucky to have her, and thank you for being here. And Nancy Allen Scannell, often attached at my hip, who is the Director of External Affairs for MSPCC, and is going to really talk about how the Children's Mental Health Campaign, which I'll talk about a little bit, is continuing to work on the implementation. So we work on policy change, but also we think about what the implementation is like, particularly as it impacts kids and their families, and also providers. So for those of you who don't know, the hospital is part of a coalition for kids' mental health called the Children's Mental Health Campaign. I'm not going to read those because you can see the 6 lead organizations on the bottom of the slide. They provide a breadth of expertise. If you need a lawyer, if you need a grassroots advocate, if you need a parent, right there, that you really have this big range of lenses through which we see things, and it really allows us to make policy or to recommend policy changes and to check with the parents to make sure we're not saying the wrong thing, or the grassroots advocates or attorneys to make sure, it's not illegal. So, so I feel really grateful to work as part of the Children's Mental Health Campaign. The campaign has been around since 2007, which is kind of a long time at this point. But there's been a lot of great work that has been done, and we continue to be having a lot of wins in the kids' mental health policy realm, including today. So. I just want to set a little bit of context before turning the floor over to Emily to really give you most of the content. So for those who remember, there was a lawsuit on behalf of some kids who were stuck in inpatient psychiatric care because they couldn't get out because there was not enough community-based care. And so on behalf of a group of kids, the state was sued. The judge found for the kids, which is great, but then gave a very prescriptive remediation plan, which resulted in the development of the Children's Behavioral Health Initiative Services, which is this array of services that are all delivered in the home or in the community, including mobile crisis intervention, the best team for those of you who are practicing in this space, integrated care, intensive care coordination, therapeutic mentoring, family partners. There's a whole array of services. You'll see them flashed up in front of you multiple times today. But what also happened is that it unintentionally created a two-tiered system where kids who had Mass Health, which was the group of Commonwealth citizens for whom this lawsuit applied, kids who had Mass Health could get CBHI services, and kids who did not have Mass Health could not get CBHI services. So clinicians and families, those of us who are on the ground, really quickly learned that we could fix that problem by getting kids who have commercial insurance Mass Health. If you have a disability, you can get Mass Health. If you have too high of an income, you often have to pay for your portion of Mass Health. So people who are paying for commercial insurance were also paying for Mass Health, but they were able to get this array of services. What ended up happening is that this kind of caught on. I'm just actually curious for anyone who's a clinician or otherwise in the room who is aware of a family who has done this. Yeah, so many. So the state ended up essentially subsidizing commercial insurances, which we do think was the best use of the state's dollars. So I walked into Josh's office, and little did I know how difficult, because I knew nothing really about legislative advocacy, little did I know how difficult a mandated benefit bill is to get passed, which is almost impossible. But really the Children's Mental Health Campaign leadership as a coalition took on what we, for those of you who've been around a little, and I see several faces in the room, we called it the wraparound bill, right, where we said these things should be covered. We got a lot of support legislatively. Several clinicians from here came and testified or had meetings or came to the State House breakfast and really talked to legislative leaders about how important this was. But the bill didn't pass. Didn't pass the first session, didn't pass the second session. This would have been the third session that we filed it. But as it turns out, the Secretary of the Executive Office of Health and Human Services, Mary Lou Sudders, who I will say was one of the founding leaders of the Children's Mental Health Campaign, which is a benefit when you're doing advocacy work. She had a different way of thinking about this. She said, this isn't a new benefit. We're not telling the insurance companies they need to do anything new. What this is something they should have been doing all along that they haven't been doing. And so she worked with the DMH and also the Division of Insurance, who issued a bulletin that basically said to the commercial insurers, and Emily will get into which commercial insurers, but said to the commercial insurers that they have regulatory authority over, that they're actually out of compliance with parity and that they need to be including this in their benefits packages. And so that happened a year and a half ago, I want to say. Yeah, about a year and a half ago, and DMH and DOI have been working together around the implementation, because you can imagine, right, when you do something through Mass Health is an entity that then, there are all of these carve-outs and whatnot, but the entity of Mass Health can say, we're going to do this across our plan. When you are doing something through the Division of Insurance, you have Blue Cross and Harvard Pilgrim and Tufts and all of the rest of them, and the implementation is much more complicated. So I'm going to let Emily, thankfully, get into what this means for kids and families and providers, and really talk about what we're looking at now that the July 1st implementation has passed.
Great.
Yes, it has arrived. So thanks, Emily.
Great. Thanks, Kate. I want to thank all of you for coming. As you'll understand, I hope, after I've gone through these slides, this is going to be kind of a complicated implementation, and you all are going to be really critical in helping families know what to ask for in their commercial insurance. So I personally really appreciate you are very influential people with a lot of families, and I'm grateful that you're here. I also just want to say I've been working on kids' mental health for many years. Sarah and I worked together on a project in the mid to late 90s. It has made such a huge difference that we now have the Children's Mental Health Campaign. Prior to the campaign's establishment in 2007, we had sort of pockets of children's advocacy, but some of it was more focused on juvenile justice. Some of it was more focused on child welfare. We did not have a unified behavioral health focus on kids, and it has made my job so much easier. And that's not the important part. The important part is,
Sure it is.
but I feel passionately about it. But it has made a big difference for the children and families in the Commonwealth. So it's, we really, really appreciate all the leaders, but Children's Hospital's leadership of that campaign. Okay, so we're going to get into some wonky stuff. So this is the bulletin that went out in December 2014. So unlike, just as Kate was saying, so when it's the Medicaid program is a purchaser. So it decides what to purchase. It has to get approval from the federal government. But when we were implementing Children's Behavioral Health Initiative, we had very, very strict definitions of what the 6 services were that we were purchasing. So we had multi-page performance specifications that then the managed care companies use. And we had money to help with implementation to get providers up to speed on how to deliver very particular models of care, and have the managed care companies doing technical assistance and monitoring to make sure that providers were doing what was in the performance specifications. Division of Insurance does not have that much power over commercial insurance. It's a very interesting balance of what's really the prerogative of the insurers as private businesses, and what are the areas that the state has some regulatory authority. So this is really about interpreting the parity law. So there was a state parity law, there's since been a federal parity law. As we've dug into it, parity is a funny concept if you think about it. What you're saying is, we want sort of justice and good care around behavioral health. But the mechanism of the law is saying it should be the same as the medical benefit. So in some ways that's good. Like, you shouldn't have a lifetime cap that you don't have on the medical side, or a copay that's really high. But it's funny, like, do we think that the physical health benefit is perfect with insurance? Probably not. So it's a funny thing that to actually try and implement that law, it should be as good as the medical. But anyway, that's the framework that this bulletin, so it's not a law, because the secretary said we've got a law. It's not a regulation, the regulation's on the book, it's a clarification. And so it is saying to the commercial insurers, there was a previous bulletin that said, parity for kids means you have to pay for intermediate levels of care. And so what that means, if you think of before CBHI, you had outpatient care, you had inpatient care. If you had intensive treatment in the home, it was usually to step down from inpatient care or to prevent, right before trying to prevent a hospitalization. But it wasn't intensive, ongoing, intermediate levels of care. So that's the level of care. There's a previous bulletin that said you should cover it. This bulletin is saying, and by that we mean 6 services. And that's what I just did. Okay, so here are the 6 services. Mobile crisis intervention, intensive care coordination, community-based acute treatment, intensive community-based acute treatment, so it's 7. In-home therapy, family support and training, family partners. Can I just see by a show of hand who knows what a family partner is? And it's no shame if you don't. Okay, so about half the room. So I'll just do it's the secret sauce of CBHI. So it's kind of like a community health worker. They are often mothers, but sometimes fathers of kids who've had mental health conditions. And their kids are now usually out of the home, so they can be in the workforce. They become coaches to current parents. Now, part of that is they have expertise of, like, how do you work with your school district and get a good IEP? So they've learned a lot about our systems. But the thing that's really powerful is that even to this day, parents of kids with mental health conditions are stigmatized in a way that parents of kids with other disabilities are not. And that is a very, very disempowering and difficult journey to travel. And that is one of the really key ways that family partners support parents. And especially if you add on to that, parents who are poor, maybe are immigrants, maybe English isn't their first language, low education, people of color, they're dealing with all kinds of layers of sort of bias and misinterpretation and discrimination. So you've got family partners who have been in their shoes. I remember hearing a story once of a mother talking about, she worked for a mobile crisis team. And like, just imagine the worst day of your life when you've had the worst fight with your husband or wife or child. You are not showing yourself in your best self. And you have strangers in your home who are assessing who you are based on what's going on. That's the moment families are in. So having someone in that intervention who's, I've been exactly where you are, it gets better, and I can help you negotiate and navigate the system together. So they're very, very powerful. They're sort of hard for insurance companies to think about because they're paraprofessionals and there's not a licensing scheme for them right now. Therapeutic mentoring is, they're paraprofessionals who work under the supervision of a clinician. They help kids with, frankly, social skills, managing anxiety in real world settings. So they do a lot of behavioral rehearsal and then debriefing with kids. So it's kind of skill building. And then in-home behavioral is in-home therapy, but from a behaviorist point of view. So those are the services. So, here's where we come to some limitations. The Division of Insurance the state does not have the authority to say to health plans, here are the specifications, you must deliver everything that we deliver through CBHI. Where this is the frame to understand this in is the state is pushing its regulatory authority in a very brave way. So the bulletin really reflects, if you look at the bulletin, it has descriptions. There are a couple sentences. So there were things we were very intentional about including. We fought a lot with the insurers on the in-home behavioral, that it had to be home-based, that the assessment of behavior had to be done in the child's natural environment, and it was not an office-based service. So we tried to like think of things that we felt like would stick. We had the authority to make stick, but didn't impinge too much on the right of a private organization to design their, and you know, they have clinical responsibility to design their own services and who they think is appropriate to deliver the service. So we're kind of walking that fine line. The service that is least like CBHI is intensive care coordination. We did not have the authority to say that they had to use something called high fidelity wraparound, which is the model used in the Children's Behavioral Health Initiative. Plans have plan-based, office-based, telephonic, intensive care coordination. A lot of them are going to be using that. One of the things to understand about this implementation is it's going to be iterative over years, in that the Division of Insurance has the ability to get data, to get reports, to keep watching, to keep going back to carriers and saying either whether it's around how they're making medical necessity decisions, how extensive their network is, or other things that might be barriers, or maybe that they're doing just office-based, telephonic-based care coordination that's not sufficient for some families. The division has the ability to keep going back and saying, we've got either the access concerns or they have the strongest authority around the access. But if they get a lot of complaints around quality, they can also talk to plans about that. But it's not like they can make plans do things in a certain way to start. It's more this ongoing regulatory relationship. So I think intensive care coordination is going to be probably the hardest. We're more hopeful about the others. Okay, so here's the critical thing. The only commercial insurers who are regulated by the state are actual insurance products. So let me say what isn't an insurance product. Probably Children's Hospital is a self-insured plan. So in Massachusetts, pretty like all the universities, hospitals, the large employers are self-insured. What that means is they hold the financial risk. So they may contract with Tufts or Harvard Pilgrim or even Blue Cross, whatever, to administer the plan. So you have a card from an insurance company, but the insurance company has no financial risk. Children's puts aside a whole bunch of money every year to cover all of your healthcare costs. And if you cost more, they've got to come up with the money. And so that is all on the company. None of that's on me. So insurance means financial risk. So the Division of Insurance only regulates insurance products where they hold the risk. So it's typically a medium to small business. And so the company, gets the contract, they're paying a premium. All the company's on the hook for is the premium. The insurance company has to have reserves because they're on the hook for, what happened when the new hepatitis C drugs came in. Really great. There was a cure. Very, very expensive. Blew everybody's medication budgets. If it's an insurance company, they hold that kind of risk. Is that clear? So the Division of Insurance only has authority over, it's like 45%, like it covers about 45% of people in the state. And the other 55% are in self-insured, and those are not regulated in any state by the state. They have to be federally regulated, and that's much looser. Now, one of the things you do see happen, so people may know there's, in the last several years, there's a new autism benefit for kids. So that, again, it was a mandated benefit on the insurance products. Now, there was a mother who works at Harvard University, organized other parents who've been bugging them. 3 years later, they add it to their benefit. So it does create an opportunity for employees to advocate to their own employer to add something like this to a benefit. So it hopefully will spread. And the other thing is out-of-state plans. So there are people who they might work in New Hampshire or they work in Massachusetts, but they are under Blue Cross Blue Shield of Ohio. Like there's those are not covered. So there's just like we don't have the regulatory tools to go after them. So this just shows you who covers, sort of who has what kind of insurance at this point. So great thing in our state, we have a very strong employer base. And here's the breakout by self-funded and fully funded. All right, so this is going to be complicated to talk to families about, so just sort of naming that. So it started July 1. Well, what does that mean? So if you think of your own insurance plan, there's an open enrollment period every year. So from the Division of Insurance point of view, this new rule covers every insurance plan that is renewed or issued in this fiscal year, so starting July 1, 19. Some plans renew July 1, a lot more do September, a lot do January 1st, some do March. So, and it's not by carrier. So you can't say like all Blue Cross Blue Shield plans roll over on a certain date. It's employer by employer. So there's no kind of pattern about it. So as you think about talking to families, it's going to be, they can call their insurance company and ask, the first thing they're going to have to ask is this a self-insured plan? If it's self-insured, there's nothing else they can do. If it isn't, then when does our plan renew? So that's a whole piece of it. Talking about the family support and training and therapeutic mentoring. So this was something that's been the most challenging for commercial insurers. And I'll just do a little bit on this. So in the Medicaid program, we spend a lot of money having the managed care companies do what's called network management. And so we are able to rely less on what's called credentialing, making sure people have the right letters after their name as a quality measure, because there's more oversight of what people are doing in the provider agencies. Commercial insurers don't have taxpayer dollars to do that. It's expensive. And so they rely on, each kind of specialty and subspecialty saying, they'll move towards, people want to have, board certified people in the different specialties. So they really rely on professional credentials to ensure quality. And it becomes a selling point for them when they're going to an employer. We can say, you know, we've got only psychiatrists and psychologists and social workers at the highest level of licensure in our mental health network. So it becomes a badge of quality for them. So family partners and therapeutic mentors are paraprofessionals, and they have a high school diploma. So it's sort of like, how do they know who, because they've got some liability, right? How do we know this person knows what they're doing? So the state took on, through the negotiations, took on the responsibility of, we're in the process of developing a certification process for both of these roles. And, you know, we're vetting it internally, then we're going to vet it with stakeholders, then we're going to work with the commercial insurers on it. So this is going to be tricky because it's a real issue for them. We're going to have to come to consensus. We don't have the power to sort of make them do something they really don't feel comfortable doing. A number of the companies are national companies. They tend to have nationwide credentialing standards. So this is going to be a challenge. So we have until, the plan is that we figure this out this year and hopefully this calendar year, so that people have time to get credentialed before next July 1. And if all goes well, then these two services will be covered next year. Okay, so this. So just a little bit, you know, as providers and knowing providers, it's going to be even harder for providers than families. Families are going to have to learn the particulars of their particular plan. Provider agencies are going to have to understand there's 11 plans. So they're going to have to learn the billing processes, the medical necessity review processes. So there's a lot. Yeah. Okay, and just to say, so the Department of Mental Health and the Division of Insurance have been reviewing the networks that each of the 11 plans have created for this. And that is something that the Division of Insurance.
Don't mind me.
What are you doing?
I'm just moving it closer.
Okay. That the Division of Insurance can say a network is not adequate. That's one of their clear areas of authority. And that's also something they'll continue to watch as this goes forward. If there are areas of the state or just anywhere where there's not sufficient capacity, that's something that the Division of Insurance can continue to work with carriers about. And we are there now. The division is also looking at the communication materials. It may just be that you know, you get your renewal information in the mail from your insurer, and they give you a link. Your manual or it is on the website. How many of you have ever read your manual, right? So parents are not going to know about this. Now we're going to talk about, Nancy's going to talk about things we're supporting and the campaign supporting to get the word out. And so listen carefully. So there'll be materials to support you, but this is where you guys are going to come in, because there just isn't, some families who haven't had experience with the Medicaid services, they don't even know what they are. They don't even know this is in the realm of possibility to ask for. So there's that barrier. They don't necessarily know that their insurance offers it. So it's going to take all of us doing a lot of public education. And I think that we'll keep monitoring it and working together. Part of what we're getting the word out about, and we'll do in successive ways too, I think, is how do people make complaints? You know, first to the insurance company, but there are also ways to make complaints to the Division of Insurance. So that's going to be an ongoing process. There we go. I think that's you.
I think you're the next one.
Next one.
Oh, no, that one. And the next one.
Hi, everyone. So, are you as confused as we were when we first? Okay, yeah, perfectly normal response. The issue, of course, is that we can't have families be confused. So the first thing we did, because what we're good at is coalitions, is to bring together to reach out to DMH and say, hey, the campaign would like to help. And then to reach out to our friends at the Association for Behavioral Health, and folks don't know them, they're an association comprised of many behavioral health providers in the state. Full disclosure, MSPCC is a very proud member of the Association for Behavioral Health. But what we wanted to do is to ensure that the language that was being used with consumers was the same language that was being used with providers. In one of our earliest meetings, in fact, what we started to talk about is what the front desk folks in provider organizations needed to know, because they're the first people to talk to a family member or to a youth who needs the service, and they really need to be speaking the same language. So Paraprofessional Advocacy League, part of the leadership of the Children's Mental Health Campaign, but in their own right really provides a direct interface with families that are struggling to get access to services and who need information about it. We were fortunate to be joined by our other partners, Healthcare for All, who folks may know runs a hotline around insurance, and the Autism Insurance Resource Center. Not that everybody is not valuable in this process, they are, but Emily referenced the rollout of the new services for kids with autism. That process looks very similar to this one. So the good news is that awful confusing, oh my God, how are we ever going to make it through this scenario has been conquered in a certain element of the services. And so thankfully, they're also willing to lend their expertise, models of fact sheets, et cetera, and have been really an important part of our development of tools. So if you back up to Emily's qualifications for the service, the first thing we want to know is, are we self-insured? So until you were told, how many of you knew whether or not Children's Hospital was self-insured? Yeah, so a lot of you did not. Right, it's because your card has an insurance company label on it. You would never know that. So, so we're developing a bunch of consumer-facing and provider-facing materials, but we're also trying to figure out where the other policy levers are. Like, do we need to make it a recommendation that DOI mandate that cards that are given to people that are insured say on it, this is a self-insured plan, so that we don't have to send people down rabbit holes. We thought first, okay, is it in the manual that I've never read? Okay.
Or on the website.
Use it as a doorstop once, maybe, but that's about it, right? But then we're told that it's not always identified in somebody's manual. So really, in order to find it, you have to go to HR. And by the way, you have to hit the right HR person. If they're not somebody who deals with contracting for your healthcare, they might not know, because it's never really been that important to people before. So we're trying to figure out ways to make things easier during this process. We will have the materials be web-based. They will be, people will be able to put their own logos on them. At the same time though, providers are rolling out materials. Some of this material is coming directly from those individual plans that Emily is talking about. So we've begun to gather some of those pieces to be sure that we're either influencing the next iteration of those documents, or that we're taking really good language from them and borrowing that and using it in the public materials that we're creating. And then finally, I would say that this group will continue to engage. We do it a lot. Sometimes we just really go to a different room and keep meeting on a different topic. I feel like that happens on a regular basis today. My day's not like that. And part of that focus will be really borrowing the materials in the Autism Resource Center to empower people to work with their employers, as Emily referenced earlier, to really help employers consider voluntarily bringing this benefit into the coverage that they provide for their employees. You didn't say this, but it was said in a public meeting, so I'll go ahead and say it, that the GIC, which covers state employees, has already made a commitment to begin that coverage as of July 1st of next year. So that's a really big chunk of employees, and it's nice that they are sort of the leading edge of what we hope will be a trend. So thank you.
Thanks, Nancy. With that, I'm going to ask our panelists to join us at the table. And I'm going to ask all of you that if you do have to leave our program early, to please fill out the evaluation on your seat. All of our programming is based on feedback of what you're interested in. That's why we're having this event today. So please fill it out and please let us know what you'd like to work on next. So we're going to move into the question and answer portion. We have some of your online questions that you've submitted, and folks on Zoom, definitely feel free to type into the chat box. Intern Lizzie is in the back. Wave, Lizzie. Hello, Lizzie. And she is going to mic you up, so please just wait for Lizzie to get to you so that the folks on Zoom and those that are going to be recording can hear your question. So I think we're going to start with Kate Guinness and a question that was asked ahead of time.
Sure. So we got a great list of questions ahead of time, some of which are related to this issue and some of which are not. So I will say I'm going to try to stick to ones that are, there's like enough for a 2-day conference on this list. I'm really thrilled that people are that engaged with behavioral health. But one of the questions is, how will payers authorize care? And I will say a little bit about that, and then maybe Emily can say something, as much as none of us is a payer, right? So, but there will be utilization criteria. Each plan, which you may know this already, that each plan has its own utilization criteria for every service: inpatient, outpatient, medical, behavioral health, substance use services. And it will be similar that each plan is currently developing or should have already finished developing their criteria for each service. So for the 4 services that are covered now, and then they will work over the next year to develop criteria for the other 2 services. They will then have their utilization management team who will provide utilization management in the same way that they do it for inpatient or outpatient. And it's really different. So for instance, I was just with folks from Blue Cross Blue Shield. They have eliminated utilization review in outpatient and inpatient settings, mostly because I think they were paying more for the staff who were staffing than they were saving in not giving people services. And so they got rid of it. So I would imagine that from a Blue Cross Blue Shield perspective, that authorization for these services will be aligned. For the other payers, it's really different. Luckily, if you work here in the hospital, most departments have folks who are doing that, and we will make sure to be reaching out to them and that they are having conversations with the plans about how this works. So,
yeah. I'll just say that we met extensively with all the carriers on their medical necessity criteria. Again, we couldn't exactly say yay or nay, but we did a lot of persuasion. They were mostly pretty good to start, and what they ended up with looked reasonable to us. So we brought clinicians who are familiar with these services on the CDHI side, review all the medical necessity criteria. So I think we're starting from a decent place. The issue always is how they're interpreted. And so I think part of what you guys will do here is make sure there's a way to flow feedback of what you're seeing and experiencing, what your patients are seeing and experiencing, because DOI is going to want that feedback, and it will take corrective action if people are being too restricted.
I think the only thing I would add to it is that there will be subtle or not so subtle differences in the exact type of service that's offered. And to the extent that that may not match what the child needs or is currently receiving. So you could be working with a family whose child is getting services through CDHI because they have Mass Health Secretary, who over the course of the coming year may have some level of coverage through their commercial insurance plan. If it doesn't match, the option for Mass Health Secondary is still there. So this will not eliminate everybody from the roles of Mass Health Secretary who need this.
Are there questions in the room? Go ahead, Josh.
What's the expectation that the commercial plans will be buying into sort of the network that's already been developed in Mass.
Emily?
Well, we were really pushing that, and we were pushing that as a solution to TM and family partners. And they're like, no way, no way, no way. Then as we've looked at their plans, many of them are doing it. And particularly the plans who use Beacon, who were already working with the network, they're pretty much using ours. So it varies.
Hello. Working in the ALS program here at the hospital for many years, I went through this with the Autism Insurance Resource Center when all the in-home ADA services became available. And I want to say that the Autism Insurance Resource Center was our saving grace because it was really like this process. I mean, we were self-insured because of having gone through this process with Eureka. So, you know, I wonder, is there going to be something similar to the Autism Resource Center that we will be able to send people to? Because I think it's hard as a clinician to even understand it, and then to explain, if it's going to be like the autism, to explain it to a family and get them to ask the right questions to their insurer is a little challenging. So that's my question.
Well, so there's a comment, you know, I wish I could tell you that there was going to just be a single point of entry on this, but there is the money, right? So as Emily was talking about the development of CPHI and resources that are there are not the resources for implementation of this. So Healthcare for All has a hotline. They have been part of the conversation around the materials and will be prepared to be helpful. DOI is going to have a line for complaints. So if somebody's feeling like they're not getting access to a service that they are entitled to, that would be an option. And then we do intend to create these set of materials. And we're having some discussion, we'll figure out how to do it. Nobody's ever going to mistake me for a techie. So, but there is a way that you can do it online to sort of have people answer a set of questions to determine whether or not they're eligible. So we forgot to have some conversation about whether and how, hopefully how we can create that. And then really link, we're trying to figure out who should be the home for this information and how then to encourage others to link to a single set of information versus putting out information that could be altered or become out of date. So we're trying to get to that kind of single source, but we can't quite do it in the same way as was done for the insurance resources.
Just to add to that, the Parent Professional Advocacy League has a 9 to 5, 5 days a week helpline too. So I think those are going to be the two resources.
There's a question.
Yes. My question is two questions technically. The age of eligibility, does it mirror CDHI up to 21 or, okay, no.
It's up through the 19th birthday, right?
Yep. Okay. And then when also the change happened with the autism kind of reform, what I recollect happening was that providers and the rates that insurance companies, commercial plans were paying providers were not as robust as, and so then providers weren't signing on to provide the service, causing an access issue. So I was just wondering if you could speak to that in terms of this specific change.
I just need to say I love the level of expertise in the room. It's amazing. So the rates that commercial insurers pay to individual providers is negotiated, right? Between each insurance company is currently negotiating with a network or has negotiated with a network of providers, many of whom are CPHI providers, to figure out what they're going to pay for each of these services. Again, I think I just want to emphasize the fact that these are not being sort of sold as a package of wraparound services. They're being sold as individual services. So they are negotiating a rate for in-home therapy, for in-home behavioral therapy, et cetera. So I can't speak to the rates that each commercial insurer has negotiated. There have been, I think there are places in the system where commercial actually is paying substantially more than Mass Health in a variety of settings. So I think there is actually concern on the provider side of things, on the community-based provider side of things. There's concern on the flip side, which is that that the providers of these kinds of services will be more motivated to take care of the commercially insured, and they need to be taking care of kids with mass health because the judge said so, among other reasons. So I think there's actually been, I've heard more concern out in the world in the other direction, that the rates are going to be more robust on the commercial side. I don't know if that's right.
I will tell you from
There's
you know,
people
we
who
are
are-
a community-based provider, and if folks don't know, several years ago, NSBCC merged with Elliott Community Human Services, so we're probably a bigger provider than most people even realize at this point. So far, the rates are good when they will all, just keep pretty closely said this, where they were already good, and the insurers that were bad are worse. So there are some that folks are opting not to engage with on these services. Our organization included, I'm not throwing anybody under the bus in this particular meeting, but where we should have been concerned about inadequate rates offered by certain providers, this is just putting an exclamation point at the end of it.
I'm just going to put in a little plug for Ghost Networks right now, which there was actually a question about it, but I'm going to tell them. So several people in this room know that we've been working on a piece of legislation related to increasing the accuracy of provider directories, so that when people are looking for a provider, they can find one who is actually doing what they need and is taking patients and sees kids, et cetera, in our community. And the insurers are all required to have adequate networks, including they will be required to have adequate networks for these services. So what Nancy's talking about, to some degree, may well take care of itself, because the commercial insurers will have to raise the rates enough that the community organizations will work with them. Otherwise, they are not going to have adequate networks for these services, and then we can talk to the Division of Insurance about their inadequate network. So these things are all kind of related to one another. You've been waiting for a while.
Hi, can you hear me?
Yeah.
I'm a staff member here, but I'm also a parent of two kids who both have CVHI and benefited from these services. And I will say that through Mass Health, this is like a big secret, CVHI. We were in crisis, and not for the first time, before somebody handed us a brochure and said, call this number, I think you can get some of these services for free. And ultimately, it was other parents who are our lifesavers. So this is very much a concern as you're talking about rolling out this program, that, you know, I haven't found Blue Cross to be a whole lot more useful in giving us information than Mass Health. It's just the times are a little shorter. So how can those of us who are also parents and who are living this help push this forward in a way that is going to, you know, it's going to make it a thing, but also make it accessible when people need it.
Well, so some of what we contemplated is creating social media posts and other kinds of materials that will get out into the networks where parents talk to each other, that will then direct them back to the more detailed information. But that has been a part of our discussion in terms of how to get the word out about the existence of the project and get people to the right materials. So if you have particular thoughts on networks that you're part of that we should know about that maybe we don't, we'd love to know that. And the same goes for anybody in the room. If you have thoughts on, hey, you know, make sure you tell X group, they connect with people in certain ways. We'd love to know that, so that when we're ready for distribution, which should be fairly soon, we're including that tonight.
I just want to mention that the Department of Mental Health funds parent organizations around the Commonwealth and who run support groups. And those are all listed on the PPAL website, so Parent Professional Advocacy League. So just people should know that's always a good thing to point people towards, because not only is there the support, but just incredible technical assistance from other parents.
And I'm gonna just put a plug in for the Children's Mental Health Campaign newsletter and also the CAN, which is our internal one here at Boston Children's, because you can get information into your inbox that then you can distribute, or you can follow, you can follow the campaign on Twitter or on Facebook, et cetera. But I find that I subscribe to other ones. I find that it's a really easy way to get information and then to blast it out to other people. We want to, scream this from the rooftops, really, honestly. So in any way that you can push it out, or if there are groups that you wanted the campaign to engage with, please let us know. We can take one more question. I'm not seeing any questions online, so if there's one more question in the room. Jessica.
First of all, I want to thank you for this presentation. I'm sitting here wondering, I hate to be the one to always bring up the topic, but I will. In terms of the representation, racial and ethnically, and also class-wise, what have been overtures to the communities of color, and what structures in the parts of the community of color have you approached to provide this information? Because the reality is that in our society, race and class really continue to matter a great deal. So unfortunately, that means that it cuts out a number of people who are like myself, who've been here for 40 years, but it tends to exclude them. And so I haven't heard any real discussion about that. And I thought I would bring it up. So I'm just wondering, there's a Black Ministerial Alliance, there's the Association of Black Social Workers in town, there are all these groups, and many of those people belong to churches, and churches are a good way to provide information for Black people who are concerned about their children because they part them out to church, like it or not. But they are in the foundation for a lot that goes on in African American communities. So I can speak to you as an African American woman. I can't speak for the other groups or the immigrant groups. But you also, I just want to comment too, it's not only getting people to go, it's also preparing people to deal with people who don't look like them. Because what happens is that people are often treated badly. I've been in Boston a long time. And, I don't go around introducing myself with my PhD, but often I have to, because that organizes me. It's only my color, I don't see anything else. So, what kind of training are people being provided so that they're receptive to a range of people, not just people who look like themselves or are entitled to the service. So I haven't heard that discussed, but I thought it would be important given the changes in the demographics in Boston, Massachusetts.
Sure. Well, I thank you for those comments, and I'm sorry you had to bring it up. We should have done that. So we have begun a pretty good brainstorm of distribution contacts, if you will, and a range of religious organizations have certainly been mentioned, including the Black Ministerial Alliance here in Boston. So the distribution plan is intended to go deep into community-based organizations through the organizations you saw there, and then giving the materials in a way that directly encourages others to use it. So that's why when I was talking about being able to put your own logo on it, if a community-based organization is going to be a more of a trusted information source for a particular part of our community, that organization can pop their own logo onto this and say, here's this information. For more information, here's a sort of a centralized website. But if you have further ideas of folks we should be in direct contact with, and you've now given me the thought that maybe we should go do some meetings with some of the organizations so that they are better prepared for the information than just simply hitting them. So I'm grateful to you. Thank you.
And I'll just talk a little bit about some things DMH is doing in general on children's mental health, but we have not plugged in this information yet. And I think part of it is thinking about the complexity of this information
takes a person-to-person conversation. But this is prompting me to think about this. So DMH did a really cool project over the last 2 years of creating something called Fable Edition, which produces children's books and videos. We produced a book, it's a beautiful book called Isaac's Story, and you can go to the DMH website, there's a link to order books, they're free, they're for like 5th, 6th graders, and there's also a video, there's an animated video, and it's about different kinds of hurt, and it's a little girl who has a broken leg and is coming back to school, and a little boy of color who was a good friend of his who was out of school at a different kind of hospital. And it's really, we've been doing community conversations around the state, some of it tied to Minority Mental Health Month this month. We're working with Barber Time, which is a media company that has TV, it's like a TV channel in barbershops, particularly barbershops of color. We just did an event in Boston with them, so we're going to be doing more with them. We know we're having a big event at Kennedy Park this Sunday with like 10,000 people. Secretary did a PSA for that work, co-sponsor. Our commissioner's going to be there, so we'll be talking there, and we'll talk to her about this. Because as I said, I hadn't thought about how to talk about that in a broadcast kind of way. So thank you for that.
I need to wrap us up because we're probably about to overstay our welcome. Thank you so much for coming, those of you who are in the room. Thank you, those of you who are online. This is recorded, so if you know your colleague who wants this information, we will send out the link to everyone who is registered, and we will make sure that you can get it and send it along. Thank you so much for coming. And fill out your evaluation.
Yes, we have your evaluations to Norman, who's standing outside waiting. If you have any questions, panelists will be potentially available, but outside this room, we're going to do papers. Thank you, everyone, and thank you, everyone online.
I know.